So good evening, everybody. Michelle Resart here from Advanced Orthopedics. Welcome to all of you from a wintry Cape Town. Rumor has it that tomorrow is the first day of spring. However, it seems that we're a little behind the curve, the season curve here at the moment. The scene behind me shows the beautiful mountains which serve as the backdrop to the Worcester Golf Course. And that picture was sent to me kindly by one of your colleagues, Dr. Theo Franken, recently retired from Worcester. So for those of you who've just joined, we've enjoyed two excellent meetings so far. And we encourage you to view the previous episodes, which are available on YouTube for those who are joining for the first time. So as promised from at the outset, it was always our intention to partner and support a truly academic program and deal with the controversies of the direct anterior approach in a balanced manner. So it seems, thanks to the efforts of Dr. Koosjerdaan and his esteemed faculty, that we've achieved this objective so far. And tonight we welcome anaesthetic colleagues and physiotherapy colleagues who will share their expertise and perspective on the subject. So our chairman this evening is a well-known and well-respected figure in the South African arthroplasty community, Dr. Dipala Moketi from Johannesburg. So Dr. Moketi, over to you, and thank you for leading the program tonight. Enjoy the evening.
Thank you very much, Michelle, and welcome again, everybody, to this third installment in a series of talks dedicated to the anterior approach. I think tonight we take on a different slant to what we've been doing with the other two talks, because tonight we are talking about perioperative care. So the emphasis tonight will be on that, and I'm really pleased to introduce my co-panelists. Let me just share my screen. All right, so we're talking about perioperative hip care today, and my fellow panelists are Dr. Henny Bosch from Cape Town. So he's got tremendous experience in DAA and also a lot of experience in direct anterior approach. We're also really indebted to Koosjerdaan, who is also on the panel today. He has really been one of the guys who spearheaded this initiative. I am also joined by two seasoned and experienced DAA surgeons who are also pioneers of the anterior approach in South Africa. So Dr. Chuck from Johannesburg and Dr. Jan Joubert from Cape Town. So that brings me to this concept that I touched upon the last time when I did my presentation, that of perfection. And this is something that as arthroplasty surgeons, we all need to strive towards. But having said that, we all appreciate that it's a very elusive concept, because just as you feel that you are it, you have aced it, then certain other things crop up. For example, there is no point you doing the perfect DAA, wonderful x-rays, only to walk past the patient in the recovery room and the patient is screaming in pain. That is definitely not good. As much as you would feel that you have done a good job, that in the impression of the patient would not be the case. So it goes beyond just you finessing the operation. We have to be able to finesse the operation at all levels, which brings me to introducing our speakers tonight. So we've got three really exciting speakers tonight, starting with Professor Sean Chetty. He is an anesthetic intensivist, and he will be talking about what is new in anesthesia for total hip replacement surgery. So Dr. Chetty he did his undergraduate in Durban and then moved on to Johannesburg to do anesthesia. And I had the opportunity to work with him at that point. And he then went on to further his education in critical care. And he also did a PhD. So he is very well vested in terms of pain and pain management. And we really welcome him onto the speaker's podium, and we really look forward to hearing from him. The next speaker is Dr. Annette Theron. She is also an anesthetist, so she's going to talk to us about perioperative pain management, essentially looking at the practical approach. So she's really going to break it down for us and make it simple, particularly when it comes to the anterior approach. So she did her primary degree, BCHB in Stellenbosch, and MED and qualification in anesthesia while she was working in Durban. And the last speaker for tonight will be Miss Leanne Lowe. She is a physiotherapist also working in Stellenbosch together with Koos. She's been doing physiotherapy on the DAA for the last 5 years or so. So she's got a lot of experience with rehabilitation of the DAA. So having said that, I would like now to hand over to our first speaker, Dr. Chetty. Professor Chetty, my apologies.
Okay, hi everyone. So thanks to Koos and the team for inviting me to speak to you. I've been asked to talk to you about what is new in anesthetics for total hip replacements. Just as a declaration, I have no conflicts of interest to declare. So I decided to step away from the conventional discussion of what is new in anesthesia for total hip replacements, because honestly, this is not really going to be, my technique of anesthetizing is not going to be of interest to you. And I thought I want to approach this topic of how is what's new in anesthetics for total hips going to be appropriate for your practice. So instead, I want to focus on aspects of care, of the operative care of the total hip replacement patient that both of us are actually intimately interested in. So what all team members want is we want the patient to get through their surgery safely, and we want the patient to ideally have an improved quality of life, especially from pain and their functional point of view. So how do we achieve this as a team? Sorry. Okay, so this new word has recently appeared in the medical lexicon called Peri-operative Medicine. And the term describes the medical care of patients from the time of contemplation of surgery through the operative period to recovery, but it excludes the operation of the procedure itself. So the intention is that those who practice perioperative medicine aim to identify patients at a high risk of death, or rather morbidity in these periods, and to work collaboratively to optimize their care rather than rescuing them from complications. Now, it is envisaged that professionals with experience in medicine and anesthesiology, as well as surgery, all have complementary expertise, and we can work together to deliver the care that reduces morbidity, mortality, workload, and ultimately healthcare costs. Okay, so why is there a need to change? So the short answer to that is so that we can progress. But a short answer is not going to give you the information that you need for us to be able to, for me to try and show you why we need to do this. So the long answer is that the non-cardiac surgical population represents a major global public health burden, with approximately 234 million major surgical procedures being performed worldwide each year. Hospital surgical mortality varies between countries across the world and occurs in both the developing and the developed world. So the African surgical outcomes study demonstrated that despite a patient's low risk profile and low complication rates, patients in Africa are twice as likely to die following surgery when you compare this with the global average. So the incidence of mortality in the ASOS study was 2.1%. Now, what we do know is that surgery is cost effective, and this intervention, because it's so cost effective, is therefore essential. And this is essential even in middle income and low income countries. And therefore it's an essential component of healthcare. So I ask you, how do we work as a team together in order to achieve what we need to achieve for our patients? So the surgical trauma actually induces a state of metabolic activation, which we call the surgical stress response. And that parallels the extent of the injury, which is characterized by hormonal, hematological, metabolic, and immunological changes. So the surgical stress response is clinically manifested as salt and water retention to try and maintain plasma volume, increased cardiac output and oxygen consumption to maintain systemic delivery of nutrients and oxygen-rich blood, and the mobilization of our energy reserves, so things like glycogen, adipose, lean body mass, all to maintain energy processes and repair tissue and to synthesize proteins involved in the immune process. So nutrition plays an important role, and nutrition relevant clinical consequences of the surgical response include hyperglycemia and whole body protein catabolism. Catabolism manifests clinically as the wasting of lean tissue, and that includes muscle and largely occurs due to reprioritization. So lean mass is mobilized, releasing amino acids into the circulation, which should be preferentially be taken up by the liver in order to allow for the synthesis of the acute phase reactants that are necessary, and then the production of glucose from non-carbohydrate sources via gluconeogenesis. So I'd highly recommend that you have a read of this great review by Paul Muschmeyer, which talks about the perioperative nutrition in the elective surgery. So there are low-hanging fruit for us. Adequate preoperative psychological reserve, commonly defined as the capacity for organs to function before exhaustion, is required to meet the functional demands of the surgical stress response, including increased cardiac output, delivery of oxygen, etc. So likewise, preoperative energy reserves, such as lean body mass, are required to support the stress-induced mobilization of the reserves so that the physiological integrity and the strength is not compromised. So surgical patients who have a low reserve, including those that are malnourished, frail, and sarcopenic, are vulnerable with diminished capacity to respond to the added demands of surgical insult. So, as I said, there are some low-hanging fruit that we can achieve in this period without much effort. Things like nutritional optimization. Are we making sure that our patients have good functional capacity before their surgery? Smoking cessation, even 2 weeks of a patient stopping smoking is going to make a difference to their outcome, both in terms of wound management, which is going to be important to you, and in terms of their functional outcome. Things like anemia correction preoperatively will make a huge impact on the postoperative outcomes, because the higher the hemoglobin, the more oxygen carrying capacity they have to deal with that surgical insult in the postoperative period. The same thing applies for chronic conditions. Are we making sure that things like blood pressure controllers are well managed before getting into theater? And the last one is cognitive impairment. For this, I want to say a little bit. So cognitive dysfunction is peculiar, and it's a peculiar challenge for the elderly patients. And that perioperative period places these patients at a higher risk for decline. Now, what's our opportunities here? It's to identify a preoperative level of function in the patients, to establish some sort of perioperative plan for the patient with the family, and then to initiate focused interventions in the postoperative period. And this can be as much as referring to a psychologist, or as simple as getting the family to agree to little postoperative games that they'll play with the patient in order to keep their mind stimulated. So just to give you a visual cue of how this can fit in. So you can see we have the preoperative period, which includes your preoperative assessment, the anesthesia preoperative assessment, and prehabilitation where needed, then surgery, and then all of the other stuff in the postoperative outcomes. We've got to keep looking back at how these interventions that we're doing are affecting our patients, and then try and manage our process accordingly. So as take-home messages, my topic to you was what's new in anesthesia for total hip replacements. And what's new is this fundamental mind shift in how we manage these patients in the perioperative experience. Now, AIM needs to be focused on physiological optimization prior to surgery wherever possible. So this new concept of prehabilitation is really important. And we must remember that any improvement in a patient is still improvement, even if it's for 1 or 2 weeks. Thank you. Philipale, that's back to you.
Yeah, thank you. Thank you very much, Prof. There'll be lots of questions after this, but I think at this time, I'd like to invite Dr. Natharon to take us to the next talk. So we will have plenty of opportunity for discussion after the talks, but I love the fact that you kept it nice and concise and to the point. Thank you very much. So over to you, Annette.
Okay, so thank you for the opportunity to speak on this forum, and I'm glad to see that there is another female speaker as well in the and maybe 1 or 2 in the audience as well. I think my key message tonight is we're talking about anterior approach to hip surgery. The concept here is that we want patients to mobilize and to recover quickly, and we're doing this particular type of surgery to minimize tissue injury and to get a quicker mobilization of our patients. So I think in very simple terms, one should keep it simple. I do see that the 2 things that were most popular was the GA with or without blocks, and then spinal with the periarticular injection as well. Now, we have to consider again, and I think Prof. Chetty has also emphasized this, that we're dealing with the elderly patient. We're dealing with patients that are frail often, very often. And then we have to consider that there are sometimes the scenario of the elective case versus the emergency cases. And again, the ASSA study has showed that emergency surgery definitely lead to worse outcomes in terms of morbidity as well as mortality. Now, the concept here is enhanced recovery after surgery. We want to improve recovery, mobilization, discharge to home. And in order to do this, peri-operative analgesic needs need to be addressed properly. However, if while addressing these, we want a safe perioperative period, we want to avoid cognitive dysfunction. And again, I see the 2 things that hamper you the most are pain as well as confusion and hypotension postoperatively. We also want a patient who's got a good experience and know what to expect and maintain normal physiology throughout this period. And we have to consider cost, obviously, and these cost and care packages that are coming forward more and more these days. So just reminding you of the pain pathways. So it's important to address pain at all the different levels, or not necessarily at all of them, but at least at some of the different levels to achieve maximum pain control. From the place where the nociceptors are activated by triggering or by your surgery that you're doing, to the roots, to the neuraxial level and up to the brain level. And you can see various drugs acting at various points, and therefore directing the correct drugs at the correct points. So I think, again, stick to the basics and to your team. this remains a team approach, and the team consists of various members. And as Prof. Chetty has alluded to, things like the dietitian, the physiotherapy team, the surgical team, the communication with your surgeon is extremely important, and making sure that you know that you're all on the same page, heading in the same direction. Rehabilitation is becoming a much more important thing these days. Physical exercise preemptively, patient education and managing patient expectation is becoming more and more important. Patient must know what to expect, when I'm going to mobilize, what is going to be expected of me, within how many hours will it be expected of me, will I have adequate pain relief to actually meet these expectations. Fasting is another big issue that we want to address pre-operatively as well. Prevent excessive fasting periods, prevent excessive periods of dehydration. So patients can carry on drinking definitely up to 2 hours before the surgery, and even sometimes up to half an hour before the surgery. This may obviously be limited by other comorbids like diabetes and reflux disease, etc. But again, every patient is an individual, and you have to individualize for the particular patient's needs. Pre-medication is important. This can be part of a preventative or preemptive approach. Preemptive analgesia basically means where you are applying pain or analgesics to a patient prior to instigating the noxious stimuli. As I've referred to the pain pathways, I think regional anesthesia, in my opinion, remains a cornerstone of the management of these patients, especially for the anterior approach. Now, I think both general anesthesia and neuraxial anesthesia has a place in different patients. And for particular medical indications, a general anesthetic may well be indicated. However, neuraxial anesthesia has a lot of benefits, which has to be mentioned. You get good muscle relaxation, good analgesia, DVT prophylaxis or prevention. You don't have post-operative nausea and vomiting risk as you have with general anesthesia, and cognitive impairment in elderly patients has definitely been shown to be less with neuraxial anesthesia. When we talk about neuraxial anesthesia, that includes spinal, the combined spinal epidural and epidural anesthesia. My preference is generally for these patients a spinal anesthetic. However, again, there may be medical indications. And again, working in a tertiary hospital, we sometimes deal with patients with severe cardiac lesions who also need surgery to their hips. And these patients may well be better fit for a graded epidural. The advantage of epidurals is that you can use them postoperatively for analgesia. However, this will limit and restrict your early mobilization of the patients. Peripheral nerve blocks are definitely something that must be considered in patients, particularly those with general anesthesia, and there are a number of peripheral nerve blocks that can be considered. I'll allude to that just now. And then the periarticular local anesthetic injection, and again, done with both general anesthesia and following spinal anesthesia. However, again, one must consider toxic doses, especially once an epidural or a nerve block has been used, and the total toxic dose of whatever is given together must be considered. So this slide is just there to remind us of the what we're trying to block. So we're looking at the lumbar plexus that needs to be blocked essentially. And this can be blocked at various levels. So a spinal would be intrathecally, epidural would be around this area, and then one can look at the other areas outside the spinal space, which includes the paravertebral space, includes the psoas compartment, and then if you look further, this is just psoas compartment. The reason why psoas compartment works really well is the nerves that we're looking at is the femoral nerve, the femoral cutaneous nerve, and the obturator nerve. And these blocks should preferably be done by ultrasound guidance. The other nerve block, which is quite useful, is the fascia iliaca block, which is quite simple to do. And then there is also Sora is a very, very helpful site looking at different blocks. And just tonight on the app, there's a new thing put in there for hip, the so-called hip block, which is nicely explained there as well. But I think what is important is to realize that Cinderella shoes not going to fit every patient. You have to consider your setting, your patient, and your surgeon. I'm just making a joke saying perhaps, but we are a team and we have to approach the patient together. So we're talking about anterior approach. We have to think about patients who's needing uni and bilateral procedures, the duration of the surgery, the total combined toxic dose of all the local anesthetics that we're using at various places, and eventually the safety of our patient is obviously a very, very important factor to consider. So Tigerberg arthroplasty, I'm not sure if this is Cinderella's shoes. However, what we do mainly for the large majority of our patients are spinal anesthesia with a periarticular local injection by the surgeon. There are, however, again, patients which are more suitable to the combined spinal epidural or an epidural. And then sometimes we also have patients that need a general anesthetic with a block. So there is not necessarily one shoe fit every patient. Just to elaborate on the local anesthetic mixture, what we are using is a 0.1% marcaine solution with adrenaline, usually about 100 mils per patient of this in total volume. What can be added to this is probably ketorolac, and what sometimes are added is morphine. The evidence for morphine is probably not a lot, and I think systemic opioids are much more effective than opioids around the joint. Ketorolac, there are a number of studies that has looked at the efficacy of ketorolac in this local anesthetic injections periarticularly, and it does seem to have improved pain scores. However, again, I think systemic NSAIDs are also extremely efficient. Postoperatively, our patients are mainly treated with paracetamol, tramadol, and morphine for breakthrough pain. And then NSAIDs can be used. We only have non-selective anti-inflammatory drugs, but selectives are also advocated. However, whether selective or non-selective, one have to be cognizant of the side effect profiles and the contraindications to the use of this. And again, patients who's had hypotensive episodes, who's had a lot of blood loss, who has poorer kidney function or GFRs, are not suitable patients for NSAIDs. And then again, for the selectives, be careful with patients with cardiovascular risk factors. And then I think what we're heading for is DREAM, drink, eat, and early mobilization. So as we have mentioned, I think Prof. Chetty has also emphasized this, consider prehabilitation of your patient, strengthening your patient, working on muscle mass, nutrition, etc. Those things are extremely important. Pre-medication, these patients are often patients with osteoarthritis, have chronic pain problems. They're already on a number of chronic pain medications. So again, using preemptive analgesia in these patients are important. This can include gabapentinoids, especially in patients who's already on chronic treatment with these drugs. Again, tailored to the particular patient and risk profile. I think fasting and keep the patient drinking, hydration is extremely important, especially with a fast-track surgery plan. Managing the comorbid diseases, again, extremely important when you want to fast-track your patients. You want your patients stable, you want your patients in a good and optimal condition prior to surgery, including the hematinics, the anemia, etc. All of those things are very, very important in the outcome of your patient eventually. And intraoperatively, my preference head towards regional anesthesia. But as I say, that can be with accompanying general anesthesia. But I think the benefit of blocking a nerve at some or other level, whether it being near axial or lower down, has definitely got a benefit in terms of pain scoring and pain risk after the procedure. I think with regards to neuraxial block, as I said, postoperative nausea and vomiting are prevented. Cognitive impairment may be prevented. Weakness may be an issue, but so may be an issue when you use a nerve block. A deep nerve block will certainly also add to the weakness of the patient. And therefore, I think pain definitely good pain management will facilitate early mobilization. Again, another benefit is the prevention of DVTs. And then, as I say, multimodal analgesia tailored to your specific patient and achieving the dream. Thank you. I think this is just to open the floor, and I'm sure there'll be a lot of discussion following this. I'll stop sharing now.
Thank you very much, Annette. There will be a lot of questions, no doubt about that. So at this time, I'd like to ask Liana Lowe, the physiotherapist.
All right, good evening, everyone. Thank you for the opportunity to speak tonight. I think there's been good groundwork being done about early mobilization from the speakers before, so we'll jump right into it. If we look at the goals for total hip replacement, for the physiotherapy goals after a total hip replacement, not much has changed in the last decade, but the physio management has changed a lot. Thinking back to a time when patients had to be on a week bed rest before starting to mobilize, and then taking almost another week to get them functional for discharge. So now in 2020, where our patients, some of our patients are discharged on the same day or even the day after. A lot have changed, and these patients, one can almost say, mobilize even better than what they did a decade ago. Enhanced recovery after surgery has become quite a buzzword over the past few years, and especially with hip replacements, we really try to apply these principles. There's strong recommendations for pre-op education and advice, pre-op physio, and early mobilization. The early mobilization has become a lot easier since we started doing anterior at Tygerberg. During our pre-op assessment, it's very important to identify barriers that might delay post-operative rehab and timeframes. Also important to note that these barriers aren't only physical, but also emotional and mental barriers, and to determine if there's a need for prehab or not. During this session, we focus a lot on education as well, as it's known to decrease pre-operative anxiety, and also to start building a relationship with the patient and gaining their trust, because this is what we need to apply the rapid mobilization protocols. Something else that I find very valuable is to do an assistive device session with the patients, fitting their crutches, teaching them the correct way of using it, the correct way of climbing stairs, doing transfers, as that makes post-operative mobilization just so much easier. If we look at pre-op physio, current evidence does not support this as an essential intervention, but I think a lot of us have seen that there's really value in that. We had a study a few years ago at Tygerberg Hospital looking at this, and the patients had improved functional scores and improved pain scores. So for a patient on a waiting list, I feel there's a big role to play in preoperative physio, as well as in select cases where barriers have been identified. That said, according to the literature, it doesn't accelerate the achievement of discharge criteria or decreased length of stay. But it do enable the patients to be able to cope easier with post-operative demands, to be able to achieve their discharge criteria in a set time. In our population, I've also noticed our patients aren't always ready for what is to come. And during the prehab, we also focus on maximizing their physical as well as emotional and mental well-being before the procedure. Last week and the week before, we've heard a lot that the DAA population performs a lot better during the acute post-operative period. And that's why I like DAA, because that's when I work with them. We see improvements in patient satisfaction. Seeing that there's no hip precautions, they tend to mobilize easier and with less worry. They have quicker recovery times, lower pain score at 24, 48, and 72 hours. And the population that I work with, often this is the only time that they get supervised rehabilitation. So less pain means they're able to do more and achieve more and prepare better for the rest of their rehabilitation period. From the literature, we also see that higher rates of these patients are discharged directly home, and it makes full sense because they achieve active range of motion quicker, which will lead to improvements in function. For example, the patients are able to mobilize to the bathroom independent. With that, improvements in independence, not having to rely on a nursing staff to mobilize with them or giving them a bedpan, and then confidence in doing that on their own, not having to rely on a carer or family members at home to assist them. Something else that I've also just noticed is the patients tend to rest a lot better without the abduction cushion. And a good night's sleep leads to improved compliance and motivation with rapid mobilization. If we look at the ERA's principles, mobilization 6 hours after hip replacement is encouraged for weight bearing and mobilization to the chair. The first time a patient mobilizes and weight bears has a massive psychological effect. And the mobilization thereafter just is a lot easier. So the sooner we can do that, the sooner we get the patients to move easier, to accelerate the discharge criteria as well. We see improvements in reported functional outcome measures, and with the DAA population, it's known that they rehab a lot faster. So quicker leaving their crutches and faster improvements in mobilization distance. That said, most of these advances are only in the first 6 to 12 weeks. But for me, that's the great thing, because that's when I work with them. Very rarely will a patient with a straightforward hip replacement need rehab for a longer period than that. And to be honest, if I get to choose, obviously I would choose the surgery that gets me going quicker, gets me off my crutches quicker, and gets me functional a lot sooner than with alternative approaches. I also feel this is the way to go with adequate pain control to facilitate same-day discharges as well. That said, rapid mobilization is not the physio on its own, and the multidisciplinary approach is very important, from the surgeon, the anaesthetist, and the nursing staff taking care of the patient. And I truly believe communication between these team members are the key. Thank you.
Thank you very much, Liana. And I'd like to just thank all the speakers today for being concise and sticking to time and delivering really high quality talks. I'd like us now to move to bring up the polls so that we can see how people voted. And I'd like at this stage to start with you, Prof. Shetty, where we can then talk about the different responses. And let's get your opinion when it comes to the different responses with your specific poll. Do you have a formal evaluation of your patient's cognitive function prior to surgery? And clearly a lot of people said no.
Yeah, so I think that it was a very nice movement from my presentation to Annette's, because she spoke about some of the challenges that cognitive dysfunction plays. And I think in one of her polls, people talked about the postoperative confusion. So there's some new work coming out now around evaluating or what's called perioperative cognitive dysfunction. And there's a whole range. So the important thing is that we need to actually just know what our patient's baseline is. Because if your patient was confused to start off with, you know you're not going to be able to get any better than that. But if you have a 75-year-old who's actually going for walks in the park every day, is able to fish, do things on his own, you need to, what we can do, and you can do that very simply in your rooms, is there's some very nice, very simple cognitive evaluation tools. A lot of them are research-based, but they're short and simple, and it can give you a clue as to where your patient is. And the important thing for that is just so you know where your patient is, and then to work with the family for simple interventions, things like doing a crossword with them in the few days that they have after surgery, bringing photographs to the hospital to show them and discuss the different family things. So it's just to jog the memory. A lot of the new work about postoperative cognitive dysfunction is that the patients are saying it feels like a fog. And sometimes this fog can actually last for up to 3 months and then all of a sudden just lifts. So, and that can have a big influence on your surgery, because the whole reason that orthopedics is changing to this approach is so that you can get these patients up, active, and back to a high quality of life sooner. But that's not going to happen if you've got this confused patient. So we need to be thinking about what their cognitive state is pre and post-op.
So these scoring systems, how accurate are they though? How often will they tell me that a patient is actually going to be confused after the operation?
So like with all scoring systems, they're not 100%. What they're going to do is they're going to tell you about the likelihood. So it's in all these scoring systems, the ones that are easy to interpret are the very obvious, so the extremes. So if you get the patient who's definitely going to be confused, or definitely likely to be confused post-op, and then the patient who's definitely unlikely to be confused post-op. But it's always the gray area that's the challenge. And you just have to look, like we do when we manage back pain, whether it's neuropathic or nociceptive, you have to look at what's the likelihood. And if in your practice you can put in place techniques to actually try and work through the postoperative cognitive dysfunction, it's going to improve your patient's outcome.
Okay, so Sean, let's move on to the next question in the poll. So you asked about treatment options for pre-op anemia, which is really not uncommon. Should you be even operating on patients with a hemoglobin of below 12 electively?
Oh, well, I think that's what I was trying to get to, is that preoperative anemia is actually really dangerous. We don't seem to appreciate the impact of preoperative anemia, especially in the elderly.
But
So
it's very common. The issue is it is very common.
Yeah, so for elective surgery, we actually need to be making sure that we get the patient's hemoglobin up. And using a transfusion of red blood cells intraoperatively is actually not the answer. The answer is actually getting their hemoglobin up preoperatively. And certainly we have oral hematinics, which I see is what most people would use, is an option, but you know that then you're delaying your surgery for a significant period of time. For purely elective surgery, I think that's probably acceptable. The other option is the IV iron, which actually works much faster, but even IV iron has its complications. And so you need to be considerate of that. I think my take home on this is, don't go to theater thinking I'll transfuse the patient. One of the things that we teach the registrars, especially in the ICU, is around the ability of transfused blood to transfer oxygen to tissues. And we know that blood lesion is actually pretty, it means that the blood doesn't actually transport the oxygen that well. So even though we're giving blood in theater, we're going to get the hemoglobin up. That hemoglobin is not as good as your own innate hemoglobin to release oxygen in the tissues. So I think if you can delay surgery to allow preoperative optimization, that would be great, because you're not just going to be improving hemoglobin in that time. In the same time, you hopefully are going to get this patient to stop smoking. You're going to get this patient to be doing pre-op rehabilitation and getting them stronger. And all of it is going to lead to a better outcome for your patient.
Okay, so let's move on to the next question. So I think at this point, the panelists and everybody who's joining us from home, you can start lining up your questions. You will have an opportunity to ask questions of Professor Chetties. Can we go to the next question on the poll?
So this one was an interesting one, and I was glad to see it was what I suspected, because the majority of people, not just in orthopedic surgery, but across all surgical disciplines, are not going to perform nutritional interventions, because this is very new to all of us. Even within anesthesia, it's only in the last few years that researchers like Paul Wischmeyer have shown the impact that nutrition can make on your postoperative outcomes. We know.
So who should be champion in this though? Because, you know, I've got my anesthetist, I've got a physician, there's me, there's a physiotherapist.
So I think what's important is that the patient is coming to see you. They have a, before they come to you, there's a trust in you. I'm coming to Dr. Moketi. So all Dr. Moketi has to do is either say, look at this patient, and I'm not asking any orthopedic surgeon to become a dietitian, to do a full nutritional assessment, but you can eyeball the patient. You can even perhaps have your receptionist have a questionnaire in the waiting room that the patient fills out. And all you need to do is you need to red flag patients. And the ones that get red flagged, you can refer them to a dietitian, or you can provide them with a pamphlet about a nutritional plan. But the idea is to make the patient aware. As soon as you as the surgeon talk to them and say, hey, the surgery is not just about this me putting in this implant for you. The surgery is about how you're going to function with this implant afterwards. And that means you actually need to make sure that you're eating a balanced diet preoperatively so that you can get your muscle bulk up, so that you're not sarcopenic, and so that you can actually mobilize with the physiotherapist in those first days after surgery, and therefore you'll have better functionality. Because for me,
let me just come in there. So that being the case, would you recommend maybe routine albumins in all these patients? Should we be doing that?
So we have, whether we like, if we were in Canada or in the US, I would probably say, yeah, we can do that. And there's other blood tests that we can do. But we have to remember that we're in a low middle income country. And even in the private sector, we're coming out of a devastation of the economy now. Many people that were upper middle income are probably going to be lower middle income or lower income now. And medical funders are not going to be able to just fund us doing albumins and globulins and things like that. So there are cheaper, simpler evaluation tools that we can use.
Let's jump on to the next question.
Lapolo, there was a question on the Q&A on ketamine in PCAs. Can Professor maybe comment on that?
Right.
Yeah, Chris, thank you. I actually tried to answer it, and then I don't know, I moved it somewhere. So ketamine in the PCA is something that we actually use routinely in my department. We don't use it exclusively as a ketamine PCA, but we actually use ketamine with an opioid. So ketamine is an NMDA receptor antagonist, and that means it acts on a different receptor to the morphine. If you're going to use it with a morphine PCA. So it's what Annette was talking about earlier. It's treating pain at multiple receptors. The NMDA receptors are receptors that usually get turned on during acute pain. And if you use low dose ketamine, it works really well. I see the person who asked it said that they have good experience, and I'm not surprised. It's because my guess is that they're probably using it with an opioid in the PCA and ketamine. You just have to be careful about how much of ketamine you put in, because if your concentration is too high, especially in an elderly patient, you're going to get that patient becoming delusional in the middle of the night, and that's not what you want, because the nurse is going to phone you at 2 o'clock in the morning to tell you that your patient is trying to jump out of the bed.
So here's an interesting one where you asked the attendees about the type of anesthesia that they prefer for anterior hip replacement. So from a surgeon's perspective, so for me, for example, I might say to you that the anesthesia that I prefer is the quickest, safest anesthetic, where we don't faff around, we just get on with it and finish. But that does not necessarily mean that the patient will benefit from such an anesthetic. So I'd be interested from your point of view, which would be the preferable anesthetic for DAA?
So I think I like what you said about it being the quickest, safest. And I think that's what all of us want. Sometimes the safest is not the quickest. It's certainly the easiest thing to do in a patient that has no comorbidities is actually going to be a neuraxial anesthetic technique. So a spinal anesthetic with an opioid is going to be a quick anesthetic. It's going to be essentially very effective because it's going to give really good muscle paralysis, but it's also going to allow the patient not to experience any of the effects of anesthesia that we don't want. Things like postoperative nausea and vomiting, and in the elderly, you can reduce but not negate postoperative confusion.
Of course, can I at this stage get the other panelists, involved, particularly on this question about the type of anesthesia that they prefer?
Yeah, so I think the type of anesthetic, I've definitely seen surgeons having preferences, and anesthetists often work in close relationship with particular surgeons, and you build a relationship with your surgeon. I think that relationship that you have with your surgeon is actually quite important, because that's a relationship of trust between you and your surgeon that basically says that I trust you to make the best choice for this particular patient and his comorbid profile. Or her profile in terms of what would be the most appropriate anesthetic for this patient. As I say, and every anesthetist will also have their own preference, and so will the surgeon have their preferences. But sometimes you have to meet the common ground where for this patient in this setting, what's going to be the safest with this patient profile overall. So as I say, I don't think there's a right or a wrong type of anesthetic. I think regional anesthesia should be key to this whole thing, because as we've seen in the poll, pain is definitely something that everybody has problems with and are concerned about. However, whilst we're trying to manage pain, we're also trying to mobilize, and we're also trying to negate all the negative side effects of opioids, which includes ileas, which includes post-op nausea and vomiting, pruritus, retention, all of those things, which is some things that we really don't want in this particular patients, especially when we're trying to follow a ERAS kind of protocol. So the whole idea of ERAS is to avoid opiates as much as possible, or to use as little as possible opioids. The other thing is, so therefore regional anesthesia remains key in the whole scenario. There was, sorry, can I answer another question that I saw, which was on the Q&A?
Yeah, sure.
So there
You
was a
will
question.
also get an opportunity, though, to answer the questions that you polled.
Yeah. Okay. So the other thing. So I think just in general, it's a common ground that needs to be found between safety of the patient, best plan, best practice for this patient, and then also I think good communication between the team members.
Sure,
That's probably the key message for me on the type of anesthetic that the patient needs.
Yeah, but sometimes we are very diplomatic, and sometimes that middle ground, it's a shift in middle ground, and we never quite get to a middle ground. So let me just ask Henny.
Follow, yes.
So you what do you prefer?
Yes, so I prefer spinal anesthesia without opioids, and that's what my anesthetists tend to use most of the time, with a bit of sedation. Some people will get general anesthesia with that. You'll do a local anesthetic block intraoperatively as well. But the opioids, I think we have to define a bit better. We're a bit more lucky in the private setting. We have the modern morphines. So it's not morphine, but it's now all the OxyContins and those things, which is a much better type of opioid. And I think we get much better results with that.
Well, what do you think about that, Sean? I mean, OxyContin, is that the right thing to be doing in these patients? That sounds like heavy stuff to me.
Yeah, so I think Henny makes a good point. They're synthetic opioids. Morphine is a very dirty drug. However, it's a very effective drug. If you're going to use an intrathecal opioid, then there's two ways that you can do it. You can either use a short acting, something like fentanyl, and that'll give you really good intense analgesia for the duration of your surgery. So nothing more than 2 hours, maybe 2.5 hours. If you're going to use morphine, your morphine is going to last for 24 hours, but there's always there's a small risk, especially in the elderly population, that patient can have respiratory complications. So if I were putting in an opioid like morphine into my intrathecal space for surgery, I would definitely want to send that patient to a high care. And then that starts negating the whole idea of rapid mobilization and getting these patients out of the hospital quickly. I would definitely think something like fentanyl, which is synthetic, can be used very safely intrathecally for your surgery. The drugs like Oxy, you're right, Henny, great great drug. The problem is we also need to be very concerned about the lessons from our colleagues in the US. They are facing a massive opioid crisis, and that opioid crisis actually started with oxy. It started with unscrupulous use of oxy, and it's an extremely addictive drug. So I definitely think it has a place. We just need to be very wary of it. I was fortunate enough to have worked in the US last year, and I've seen the devastation that's done and what it's done in terms for the patients who actually need it now. So now it's so difficult to get opioids in the US that you wouldn't be able to actually give a patient 2 to 3 days of an opioid to get through their pain after their hip because of the risks that they're having there. So we can easily use oxy. I think it's a good drug, but we just need to be wary about how we use it.
I totally agree, and I think that's how we use it.
Okay, can
low dose, short, that's it.
Sure. Can I be philosophical here? So when it comes to the operation itself, the patient feels no pain. But we haven't quite, so that perfection thing, we haven't quite sorted out the post-op aspect of this whole thing. Because if you do not have any pain intraoperatively, why are we failing when it comes to the post-operative pain? Why are we ever going to get to a state where the patients have no pain post-operatively?
Can I jump in there, Lipale? I think that we need to, like COVID has forced us to take the next big step in how we communicate. For example, this webinar would never have happened last year because it's like we weren't ready for it. For me, what we need to do in terms of pain management is we need to take that next step into looking at regional anesthetic catheter-based techniques where we can send our patients home with these catheters. And this is done in many European countries, and it's done in the US. Now, when I was still at Joburg Hospital, this is an idea that I would love for us to have started. And the argument that I got back was patients that we're dealing with in the state sector, we're just not there yet, because you need to make sure you have systems in place where people can get back to the hospital quickly, that there's a good understanding of any side effects. But I think we're at that point, at least in the private sector, where we can start this type of initiative. If you have low dose local anesthetics in a wound catheter or a catheter-based regional anesthetic technique, I think that we can get to this panacea that you talk about of no pain, or at least really reduced pain in that post-operative period, and the patient can then do their intense physiotherapy and be able to be mobilized and get on very quickly. Of course, can I jump in here? Because I see someone's put a question on the chat about that, and they said that you have a spinal and a GA routinely. And I think like Annette said earlier, your perioperative team, so the surgeon and the anesthesiologist will, in most cases, certainly in the private sector, be working together and have a system that works. And if that works for you, that's great. But you need to be cognizant of the fact that any anesthetic, a regional anesthetic or a general anesthetic, causes a drop in your blood pressure. When you combine those two, you're going to get a more profound drop. And one of the big concerns that we have with postoperative cognitive dysfunction is the drop in blood pressure can actually lead to a relative ischemia of the brain and increase your chance of postoperative cognitive dysfunction. So I remember, I think it was Lepale that your theater was H27, if I remember correctly. And we used to always talk about maintaining the blood pressure in that orthopedic theater, because Granny, often the family will say, Granny was just never the same after her hip. And it's because if we aren't really careful in managing that blood pressure, Granny may have had some mild ischemia that no one realized intraoperatively, but they see it cognitively post-op. Daniel Sessler, who is a big anesthetic researcher at the Cleveland Clinic, they've got this massive database, and they found that that the drop in blood pressure is the 20% from baseline, which is what we've always been taught in anesthesia. But interestingly, they found that there is an absolute value, a mean arterial pressure, at 75, a mean arterial pressure of 75 is where you start seeing a decline, but anything less than 65 is where you see a massive drop or massive increase in your risks. So even if your patient starts off with mean pressures of 65 and you are allowing yourself a 20% reduction, we should never be dropping below a mean arterial pressure of 65 intraoperatively, because that's where they've now shown in this big Cleveland Clinic database is where you're going to get cognitive dysfunction. So spinal and GA is great if it works for your team, but then you've got to make sure that you're maintaining blood pressure. Otherwise, you're putting your patient at a cognitive risk post-operatively.
Okay, Anna, can I just ask you a question? And this has to do with, so a lot of patients are hypertensive. And when they come for their operation, so a lot of the recommendations will say, take your blood pressure medication on the day of the operation. But post-operatively, should you stop the antihypertensives and monitor the blood pressure before you start them again? And if so, when would you start them? So in other words, would it be reasonable to stop all blood pressure medication post-operatively until the blood pressure comes up?
Yeah. So firstly, preoperatively, the patient should continue with the antihypertensive as prescribed. The only hypertensive that I would consider stopping on the morning of surgery would be ACE inhibitors or the ARBs, like losartan, for instance. And that's just because of the risk of hypotension intraoperatively with these patients. However, postoperatively, I think you have to monitor the patients, obviously, a little bit longer. Make sure that
what is this little bit longer? 2 days, 3 days?
So no. So I think if you had done a spinal anesthetic, your spinal anesthetic usually recede within 6 hours, by which time your patient should be back to normal physiology. And often what happens is these patients then actually become sometimes a little bit hypertensive, but it varies from patients to patients, especially if they hadn't taken the antihypertensive, so they've missed some doses now. It also depends, obviously, how your surgery went and whether there were blood loss or any other complications intraoperatively. But I think if the surgery went without complication, there were minimal blood loss, and the patient had a straightforward anesthetic, these patients should really recover to normal physiology within about 6 hours, which is often the time that the physio want to actually get them up and about. And it also now again depends on your patient's background physiology. If your patient's been well controlled on his BP treatment, this patient should be actually be able to mobilize and continue back onto their normal treatments. However, I think it's just important to monitor. If the nurse does monitor the blood pressure is low, then it's obviously reasonable to omit the BP treatment until the blood pressure recovers.
But generally after that anesthetic, the blood pressure will be lower than the pre-op blood pressure anyway.
Well, and usually, I mean, it should just be normal. It should not be excessively low, because if it's excessively low, then something else is going on.
Altogether, yeah.
Yeah.
So generally runs a little bit. If they were hypertensive, it generally runs. They become more or less normotensive for a few days post-operative.
Yeah. So if they are normotensive, then they should continue with their blood pressure treatment, in my opinion, because again, eating, drinking, hydration is important, and back to normal function is important, and also negating other risks perioperatively remains important.
Can I get Dr. Chuck? Is he there, Chuck?
Yes, I'm here.
Yeah. So again, you look at this poll and you see that the big issues here are post-op confusion and hypertension, and then pain. And it is really post-operative pain. What do you do? What do you do in your practice to control the pain?
I think if somebody mentioned before, I think it's a big difference between a private practice and a government institution, that obviously we have a much better facilities and options to use to the point. In my particular practice, before the COVID came in, we were in vast majority of the patient using a general anesthetic in combination of the regional block, which is either suprainguinal fascia iliaca block or a pericapsular nerve group block that was done in addition to the general anesthetic. And the general anesthesia is controlled by the entropy control. So we can control the amount of general anesthetic basic on the brain waves. That's how I, as a orthopod, understood what my anesthetist was telling me. With the COVID, we were forced to use more a spinal anesthesia with a basically sedation to avoid any kind of contact with the airways as much as possible. In my short experience comparing those two groups in the last 4 months, 4 months, is that there is no significant difference in a cognitive function afterwards and in a rehabilitation following the either of the two types of anesthesia. And amount of the analgesia that has to be used afterwards is a very, very small. I don't remember when last time I had to prescribe opioid to my patient.
What do you give your patients?
Post-operatively, they're usually having in the first 24 hours, they have 1 or 2 doses of IV NSAIDs in combination with Prefalgan paracetamol IV. And following that, they go on to the oral anti-inflammatories for a period of 10 days post-op with analgesia, which is in my practices most of the time either simple paracetamol or in a more sensitive patients, if you will, Synaleve. So this is what they get discharged out of the hospital. And average discharge in my practice is 2.1 day in the last 14 years. So they get mobilized in the first 24 hours. The only difference, what I wanted to mention, is that with the spinal anesthesia, I saw a more need to use a catheter because they get quite significant retention. So we put the rule down that if we're using a spinal anesthetic, we always put the catheter in theater and get removed after 24 hours. But that is one of the things with the general anesthetic I never used. None of my patients with the GA and the regional block required or none. There is possibly about 1%, maybe 2%, mainly the young, strong males, they will require catheter in the first 12 hours because of the muscular spasm and retention. But otherwise, in general, they don't require catheters. But with the spinal, yes, women and men.
Right. Right. Can we advance to the next question?
The next question was on physiotherapy.
Right. Okay. All right. So I'll tell you what. Why don't we then get Liana to field the questions on the physiotherapy. Of course, are there any questions on the Q&A at this time from the other delegates, people that are attending?
I think the one question that's not been answered is the role of dexamethasone in the perioperative space.
Yeah, very good question. Annette?
Hi. I was just typing on the forum. So I think, again, if you are using general anesthesia, prophylaxis for post-op nausea and vomiting probably is indicated, particularly when an ERAS pathway is followed in the patient. And that would include the use of dexamethasone and ondansetron intraoperatively. The added benefit of using dexamethasone is that it will add to your analgesia as well. But again, dexamethasone is not without risk as well, particularly, for instance, in diabetes patients, that will influence your sugar again. It may also influence infection risk. But I think on the whole, for ERAS pathway, ondansetron and dexamethasone for general anesthetic indicated. For spinal anesthesia, I don't use it. I don't feel it's necessary. I'm also going to just comment back on that urinary retention. And I think another thing that I just want to comment on in terms of the pain management is I do think the surgical technique and the handling of tissue is very important in the postoperative pain the patient experiences. So good surgical technique can also aid post-op pain and analgesia. Urinary retention. I think here again, if you hydrate your patient properly preoperatively and let the patients continue to drink. So there was a question on the Q&A asking what type of drinks can patients have. So clear, sweet drinks, things like Energade or those sort of drinks are fantastic because it contains energy or carbohydrates and can provide hydration. So patients can continue drinking. They're not so dehydrated when they come to theatre that you end up giving them a whole lot of fluid intraoperatively. The other important thing is perhaps just the habit of having patients pass urine prior to surgery, so they don't come with a full bladder to theatre. And then again, a simple measure could be is just to check whether the patient has a full bladder before you leave theatre, and a simple in and out catheter before they leave the table can negate the problem of leaving an indwelling catheter in these patients. I must admit, I still prefer, and again, I think spinal anesthesia, urinary retention is a risk, but so is it with other use of morphine, for instance, as well.
Sure. Can I understand that Dr. Lisa Bottelen is one of the delegates. And if she's available, maybe we should invite her. And you as well, Sean, Annette. When it comes to new things in terms of anesthesia for joint replacement surgery, has there been any work on cannabis specifically in connection with joint replacements? Because it certainly helps in terms of pain and also in terms of nausea. And to my mind, it just looks like it would be something that would be useful for the DAA.
Just regarding the cannabis, I don't have any experience with regards to that. But what I do feel that needs to sort of be emphasized is I think the shift of anesthesia, specifically in joint replacement surgery, to going towards focusing on adequate and good regional anesthesia approach, and that will avoid the opioid use and all the pitfalls of opioid use perioperatively, which is, I think, a lot of the reason why most of these patients do suffer from all the complications that we've just been speaking about: urinary retention, nausea and vomiting, and all the confusion. A lot of that is actually due to opioid use. So if we can try and minimize that by using effective regional techniques, and I think there's a huge shift towards finding techniques that are not actually just providing partial analgesia, but actually exactly with the point that you were saying earlier is why are we struggling with pain with these patients when intraoperatively we're not having a problem, but post-op there's a 40% of the panel are answering that there's pain is a problem. And if we find regional techniques that are adequate and good, we will avoid most of these problems that we're talking about. And I think that's when Chuck, and obviously as a team, as part of Chuck's team, that's our goal. And we've done, I think, pretty well in that I think that the gold standard block and regional technique that was used and in France is still used today and very, very popular is the psoas lumbar plexus block. That is, unfortunately, in South Africa was hugely unpopular because it was a technique that was described in a paper in 2002 and became extremely unpopular because they had very bad complications, sudden death, cardiac arrest. And in that paper, many people were extremely fearful of this block, and most anesthetists stopped performing it. But actually in a paper in Germany in 2017, they did 10,000 lumbar plexus blocks under ultrasound guidance with extra safety rules as well. And none of these patients, not one, had a complication. But a lumbar plexus block with a GA provides excellent analgesia for total hip replacements. And in fact, that is why most of the patients we do either a lumbar plexus block or we do a suprainguinal fascia iliaca block with local infiltration. And I think that's the issue is that I think you can choose a variety of techniques, whatever technique you are comfortable with, because some people aren't taught and don't know the technique of lumbar plexus block, and it is a difficult, deep block. But there are other ways of moving around that. And there's a whole host of new things that are coming up, and interesting things and fun things coming up. There's a new block coming up called an erector spinae block, a lumbar, and they're doing this in New Delhi, and with unbelievable results, and it's extremely low risk. It's a block it's a fascial plane block, which means that you're not going directly for nerves and you're not going anywhere near epidural paravertebral spaces. So there's stuff being written about that. Still a bit of controversy because it is a posterior block going for an anterior compartment. But I think that is I think the crunch and the key to this whole I think avoiding of a lot of these things that we've been talking about would be if we give effective, good regional anesthesia that covers that initial pain. I think after a direct anterior approach always seems to be quite it's a short period. It's that 24 hours post-op that if we can get them through that, once they get up and mobilizing and they're either on their perfalgan or signer leave, they actually do extremely well. But just to get them through that first 24 hours with either once-off shot block, and we don't necessarily even have to put catheters into these patients. Generally, actually, for a direct, yes, for a total hip replacement, posterior lateral approaches, a catheter is great, but not, I think for a direct anterior approach, effective, good once-off block, they do extremely well.
Thank you very much. So you favor blocks and general anesthetic. Are we in agreement here? As I've got Professor Chetty, I've got Annette on the panel here with me, and I'm not quite sure if there is agreement in terms of what the ideal is when it comes to anesthesia for DAA. Or am I misjudging or misreading the situation here?
I think what my feeling is exactly what Annette did allude to, is that saying that it definitely is patient specific. So I think in certain scenarios, a spinal with sedation and intrathecal morphine, if a patient is going to a high care situation, will be a fantastic, and we are doing that, and we have been doing that in this COVID environment of avoiding airway manipulation and anything like that. So we have been doing spinals, and patients have been doing extremely well on them. But it does mean, as we were saying, about certain things of going to high care and needing that. But intrathecal morphine with a spinal is an excellent option for a direct. So I think, yes, I think a spinal with intrathecal morphine, with or without, if you're not going to use morphine, then to use a regional block with that. But definitely the point, I think the emphasis is on effective, adequate regional block. And I think then you can avoid a lot of the complications.
All right. Okay. So let's go to the physiotherapy. So question is, when do you start weight-bearing mobilization post-total hip replacement?
So I think this question links well with the last question as well, about what limits early mobilization. And I'm glad to see that most people are mobilizing them early. In our setting, we've struggled with the 6 hours. We've tried to apply it, but there's various barriers to that. But the sooner they mobilize, the better. Often the limitation factor is pain. And I just want to throw it out there. Pain is also subjective. Yes, I do understand that the patients are experiencing pain, but I've often had patients refusing mobilization initially. And when I win the argument, they often, if not all of them, will tell me they feel a lot better after moving. So also moving that first time, that big psychological effect thereof, and also getting the circulation going, getting them moving, that also plays a role in decreasing their pain.
Okay, so we're going to change tact here. Now I'm going to ask the panelists to join me. I'm actually going to ask some possibly controversial questions. So Dr. Hans Jacobs, are you there?
Yes, Lepolo, I'm here.
Yeah, so listen, can you just take us through taking consent for DAA? Would you do it any differently from total hip replacement using any other approach?
Yes, no, my consent is exactly the same. I will counsel them on different complications, but our consent is exactly the same. I'll just counsel them differently.
Okay. And what do you mean differently?
So if I consent them for a lateral approach, I consent them for gait abnormalities later on. If I do a posterior approach, I'll counsel them on dislocation rates, anterior approach, lateral femoral cutaneous nerve, neuropraxias. So I'll just counsel them differently, but the consent stays the same.
Johan, would you do anything differently in terms of consenting?
Yeah, no, I'll do the same. I'll just highlight specifically related to anterior, but I do emphasize also the advantage of early mobilization. And just to tie in with Liana, you have to tell that patient that you're going to mobilize them early so that they can catch on early on. And if everyone speaks the same language, the patients respond better. So you also have to counsel your physiotherapist to believe in the concept of early mobilization. But in terms of, so this is part of the preparation for the patient. But the consent as such is a standard consent form, but we will highlight specifically anterior, the slight advantages, but I don't think there's significant different risk factors, except maybe for the nerve, the lateral femoral cutaneous nerve. I would say that's,
Do you specifically tell them about that?
I do.
Right. What about, let me direct this to you, Annette. In terms of DVT prophylaxis in DAA, anticipated that the patients will mobilize much quicker. In terms of the anesthetic, do you do the anesthetic to try and mitigate the DVT risk in any way?
So again, I think regional or neuraxial anesthesia has shown to decrease your risk for DVT. That's just a point in itself. And then I think it's still important to obviously treat the patients. And then obviously the only thing with especially with the placement of deep blocks, as well as epidurals or spinal anesthesia, is just to consider the timing of when to start Clexane, for instance, post-operatively. If the patient is going home, however, then that's another issue, because then you probably move on to another form of DVT prophylaxis.
Lipalo, can I quickly come in here? DVT is a strange thing. All the research has been done many years ago, and most of them is done on lower leg asymptomatic DVTs. Today, in the sense of ERAS and rapid mobilization, where a patient comes in and can get their surgery and be discharged within 1 day and be more mobile than they were before the operation, the question really remains, how aggressive do we need to treat DVTs in this group of patients that you do rapid mobilization? Are we just not treating the litigation process, or are we really treating hard evidence? Yes, surgery is an initiator of inflammatory process, but so is a lot of other things that we don't do DVT prophylaxis for. So I actually think a lot of research needs to happen in rapid mobilization, hip total arthroplasty, to see really if we need to treat so aggressively DVTs.
Yeah, so we keep, to me it almost seems like we're moving forward, but we keep taking a step back. And you're quite right, when it comes to DAA, I actually don't know what to do. So I just stick with what I've always done, but we're probably over treating patients. I'd like to hear from Dr. Chuck, so maybe just briefly, what his opinion would be in terms of DVT prophylaxis, specifically in DAA.
I can just quote, we just published the international paper on our AMIS results for the last 14 years. And in my statistics, we have a presence of DVT of 0.2% and we had presence of pulmonary embolism in 0.13%. In other words, there was 2 patients among 1,454 patients. What the point is that at the time, up to 4 years ago, 5 years ago, I was using a DVT prophylaxis of period of 3 weeks. And we had at that time, we had 3.8% of the wound dehiscencies or problems related to the wound. Since I dropped that DVT prophylaxis to 2 weeks.
Hang on, sorry. So you dropped it to what though?
I dropped it to 2 weeks, to 15 days post-op. From 21 days, from 3 weeks to 2 weeks. The amount of wound dehiscencies dropped it down for 70%.
So do you even need it at all though?
Sorry?
Do you even need it at all?
This is the question that I'm asking myself now after 15 years. Is it really necessary if you're having 4 patients among 1,400 patients of DVT with the early mobilizations in a DAA? Is it really necessary to use a prophylaxis? And my honest answer, which is a completely non-scientific, is that I'm using it purely for the legality point of view. Because I'm not sure what's going to happen if somebody sue me that I haven't used prophylaxis and something catastrophic happens. I don't have enough evidence in the literature in the world that can be joint replacement of that value or the hip replacement can be performed without any thromboprophylaxis. I know that there's a lot of literature about using aspirin and using different methods of usage, but I'm not aware of any article that shows that actually a major group of patients that were treated without any prophylaxis. That does not exist. And this is a big problem for me in private practice to implement that regularly, even if I have only 4 patients in the last 15 years, that I can say I can freely go and not use any prophylaxis at all.
Yeah,
I'm not prepared to do that.
Because it looks like we're back where we started and people are giving aspirin. Okay, all right. So all that's left for me to say is to thank our speakers today for a really, really very stimulating talk on matters that are very closely related to the DAA. And also what I liked was the emphasis on teamwork when it comes to looking after patients who have, or patients that undergo the DAA, that it's not just you as the surgeon, it is you and the rest of your team, and you have to work together. There has to be communication for you to have a successful DAA outcome. I'd like to thank the speakers, Liana, Sean, Annette, and the panelists. And all that is left for me to do is to hand over to Michel so that he can let you know about the next diet of this exciting series. Thank you.
Dr. Moketi, thank you very much. To all the panelists, thank you very much, especially to our attendees who listened in on this 3rd Monday night evening. And thanks too to our team, the advanced team in the background who've made this all happen. So we look forward to seeing you all next week, Monday night. I think we can start this series on Netflix and maybe it can continue. So anyway, thanks again, and to our guests tonight. Thank you. Good night.